My name is Rahul Banerjee. I'm an assistant professor of medicine and a myeloma specialist at the Fred Hutchinson Cancer Center in Seattle, Washington. And now I've been asked to talk about what's new in newly diagnosed multiple myeloma in 2025, and in particular at this particular American Society of Hematology ASH meeting in Orlando, Florida. In short, nothing has changed immediately in this particular setting. I think the standard that really has been established over the last year at sequential meetings and publications is the idea that the default for all patients with multiple myeloma should be consideration of a quadruplet, which means a CD38 binding antibody like daratumumab cetuximab, a proteasome inhibitor like bortezomib carfilzomib, an IMiD drug, typically lenalidomide, and dexamethasone. 5 years ago, we would have said, only the healthiest of patients get a quadruplet, or only the high-risk patients get a quadruplet. Now I would say everybody. Even the patients over 80, there was data presented published earlier this year, I should say, from the Norwegian group, the REST trial by Frida Askeland and Fredrik Schjetholt, showing that even in patients over 80 whom you don't think can tolerate a quadruplet, ironically, if you get rid of the dexamethasone, and I love getting rid of dexamethasone, if you get rid of dexamethasone after 2 cycles and keep the other 3 drugs, many of those patients can tolerate a quad and do quite well. So again, that is the backdrop here. Pick a quad, any quad, for the vast majority of newly diagnosed patients. The unanswered question is which quad? Dara VRD, daratumumab and bortezomib, Dara KRD, daratumumab and carfilzomib, ISA VRD, has isatuximab and bortezomib, ISA KRD, has isatuximab and carfilzomib. How do you choose? Let me know if your doctors find out, because we really don't know at the current time. What I will say is Dara VRD tends to be the default. Again, daratumumab, bortezomib, lenalidomide, and dexamethasone for our patients in the U.S. with newly diagnosed myeloma, based on studies like the Griffin study and Perseus study, and now the Cephia study. ISA VRD is entirely reasonable for patients based on the IMRAS and benefit studies. Many of these studies are out there. What was interesting here at the 2025 ASH meeting is there has been a perennial debate between bortezomib and carfilzomib in multiple myeloma, newly diagnosed myeloma. Up until this meeting, in the relapse setting, carfilzomib, the brand name is Kyprolis, has outperformed bortezomib, brand name Velcade, in the Endeavor trial. In frontline myeloma, there was a big endurance trial, a cooperative groups trial, meaning run by the doctor, not by the pharmaceutical companies, looking at KRD versus VRD, and there was really no difference between them in terms of outcomes. However, most of the patients did not go on to transplant, and the carfilzomib dosing they used was 36 milligrams per week, twice per week, which I'll hazard a bet that none of you listening to this have ever received. Most patients nowadays receive 56 milligrams once a week, or 70 milligrams once a week, prescribed once a week. Here, there was a Polish-led study called the COBRA trial of KRD versus VRD in primarily transplant-eligible patients. At face value, KRD blew VRD out of the water. Truly, MRD negative rates were better, efficacy was better, safety was the same. Devil in the details. That particular study, patients who are on carfilzomib, on that arm, stayed on carfilzomib for about 1 to 2 years, basically, going from once a week to once every other week. The bortezomib arm, the VRD arm, only was on VRD for about 6 months. So it wasn't a fair comparison of K versus V, bortezomib versus carfilzomib. So basically, all the arguments that we tend to have in the myeloma field will continue both before and after the COBRA trial. And again, I'll come back to what I said earlier. Pick a quad, any quad. So if you're newly diagnosed with multiple myeloma, talk to your doctor about whether a quad is right for you. In the vast majority of cases, it would be. Practically, I'll tell patients, and I tell other doctors this, just because you start with a quad doesn't mean you are legally required to maintain the quad at full intensity. Most of my patients drop the dexamethasone. Lenalidomide dose comes down due to side effects, et cetera, et cetera. So starting with a quad isn't something that you have to stay on a quad for it to work. Most patients in the real-world setting, the regimen they start looks very different from what they end with at the end of induction, but that's okay. Starting with a quadruplet gets you your best foot forward to knock the myeloma into remission the earliest and feel better sooner. Whether that is with carfilzomib or bortezomib remains an unanswered question.
If our videos have helped you in any way, and you're able to, please consider making a donation to help us continue this important work.
Your gift will go 3 times as far when we reach $500,000 by the end of the year.
Every contribution, big or small, makes a difference, and we're deeply grateful for your support.